So this interest came out of the minimally invasive movement in spine surgery, which was sort of like 2005, 2004, when people began taking microscopic decompressions and mini retractors and starting to do more complicated surgeries out of using those techniques. And at this point, sort of maybe 15 years later, we can see that a lot of those techniques stuck, but a lot of them didn't. There was a lot of things people were trying and doing back then that did not stick. And one of the interests I had was obviously trying to take adolescent idiopathic scoliosis and treat it minimally invasively. So very often that means traveling around and watching other people who are more on the MAVEN spectrum and seeing what they're doing. And so I did do that. I traveled all over the country and watched a bunch of people take care of adolescent idiopathic scoliosis and other deformities minimally invasively or less invasively, and saw percutaneous cases. And but when I finally saw some mini open approaches, I think that I figured out a way to put this together to correct adolescent idiopathic scoliosis. Now, we still sort of have a limited set of indications. We'll cover that, but this is the academic data that we've developed around it and presented. Now, this minimally invasive technique or mini open technique is not naturally adaptable to current workflow. And so instead of approaching the spine, placing all your implants, doing your loosening, and then doing your reduction, you have to plan your workflow pretty specifically. So that's one challenge, is the cadence of the procedure. Obviously, sometimes you're seeing less of the anatomy that you may need for doing releases or placing implants. And placing implants is a challenge because you do have much less visualization. So in terms of your three-dimensional sense of what the deformity is, that's even more important in minimally invasive. So we started, this was our general approach, was to take the longer incision, divide it up into three smaller incisions, and then mobilize those incisions laterally. So with those three incisions, mobilize them side to side and enter the fascia, and then develop this interval between the multifidus and the lateral paraspinals, and come down on the very edge of the lamina and the facet. But different than what I saw in most places, also developing a submuscular tunnel under those incisions. So because this is a fusion procedure, and this is a procedure we want to last, this child or young adult's whole life, one of the major complications of deformity surgery is non-union. And so getting the bone perfectly exposed at every single level, even under the areas where there is no incision through these submuscular tunnels, and making sure these submuscular tunnels don't actually cut any muscle, but actually explore this interval, were all goals as we started doing these procedures. But I was confident that we could do exactly the same procedure through this minimally invasive approach. So there was no leaps of faith in terms of conceptualization, or I knew that we could do the operation this way. It was just developing some knowledge around indications and skill around doing it. And so we presented this data, I think in 2018 at a couple of meetings, looking at our 2- and 5-year cohorts, and just trying to see if there was a difference in complications, what kind of complications we were seeing, and then how did those compare to the best data from the study groups. And so we looked at our first 61 patients. I think we're up to over 100 kids now, and looked at all the standard metrics. And this includes patient-reported outcomes. We do PROs in our office as part of every patient. So we had all that data to mine, and then we did standard statistics on the groups. And so if you look at this data, this is just very standard data for any group of idiopathic scoliosis patients. In terms of BMI, age, and sex distribution, we were taking care of some older patients initially with this. So, we did do some older patients in their 20s, 30s, and 40s. And then in terms of operative time, that is a long operative time, but this was, again, our first 60 patients. And if you look at blood loss, we were sort of doing these surgeries with very, very small amounts of blood loss. Correction was very good, kind of 75% correction. And post-op SRS-22 scores, that may look like a little bit, that's a little bit of an arcane measurement there. But usually for idiopathic scoliosis, you can expect a post-op SRS-22 score to be between 4.4 and 4.6. And so you see that our scores were right in that milieu. And then Oswestry's, again, under a 12 is considered normal, and our 2-year and 5-year post-ops were normal there as well. And they did have a little bit of pain. That's on a 100-point scale, so 22 out of 100. So again, typical levels for idiopathic scoliosis treatment. If you look at again, this was just the graphics of the correction. Oh, went too far. And these were the graphics of the other PROs that we do. And the important thing we were trying to see is in the patients that we were able to get that hard follow-up on, that the PROs were the same. We did have one patient show up with a late complication, which was sort of the feared non-union at L2-3. And that has been our only non-union in our cohort that we have found. And oddly enough, there was a L2-3 non-union, but then the level below had an L3 pars defect. So the patient actually got revised and extended down to L4, which is unfortunate. That's always sort of the level we're trying to avoid going to. So this was our pretty good. This is some examples. And you see this sort of the 3 small incisions, and you see, I think, good deformity correction, consistent with what you would see open. So this was our original 2 and then 5-year group, looking at the group, and we thought we were happy with these preliminary results in terms of outcomes and complications. So then the question, so after I presented that set of abstracts, I got the question, so what? From very often when you're giving these podium presentations, that's the first question you get. What are you gaining by taking it upon yourself to do this slightly longer procedure? You may save some blood loss, but what are the actual other benefits? Since that single arm study doesn't really show anything. So we went back and did a comparison study and looked at open and minimally invasive techniques. And since we had been doing patient-reported outcomes throughout the initiation of our practice in 2002, we were able to go back and actually case match all of our patients very precisely for a case match study. So we looked at 21 patients who had MIS correction who met the admission criteria, and we case matched them with 19 patients that had open surgical correction. And, we matched them by age within 2 years, curve within 5 degrees, and number of levels within 1. And all the other metrics were evaluated as well. Same minimally invasive technique that I briefly showed you in the first talk. And then again, did standard comparison statistics. And our groups were very similar in terms of age, curve size. The reason you're seeing that average mean Cobb angle of 50, only just a little bit more than 50 degrees, is when you include the Lenke 5 curves, the lumbar curves, you'll have some smaller curves, some 43-degree curves, some 45-degree curves. And so that sort of balances out on the other end, the 60-degree curves or 65-degree curves you're doing in the thoracic spine. Flexibility index was the same. Mean surgical time was a little bit longer with the minimally invasive group. And we'll talk a little bit more about that later. Blood loss was statistically significantly less. And length of stay using the old sort of discharge protocols was significantly less as well. And so this is the graphical representation of curve correction and really getting the same curve correction with both techniques, open and minimally invasive. And looking at the scores, what you do see is a slightly better set of scores at the 1 year and 2 year. Minimally invasive seem to recover a little bit faster and end up doing a little bit better in terms of their scores, but some of these were statistically significant, some of them were not, but they were small differences. There was no big home run difference, but the minimally invasives did seem to do a little bit better, especially at the early time points. And then this is graphical representation of blood loss and length of stay. That mean surgical time was actually, that open should be 314, not 393. So the minimally invasive was taking longer. And then this is the graphical representation, and you see at every single time point, whether it's post-op or at 2 years, the scores are a little better. It just doesn't reach statistical significance at most of the time points. And again, this is a graphical representation of a minimally invasive case in terms of number of levels fused and amount of the correction you get. It's comparable to open. And this was that young lady. Looks good in terms of deformity correction. And this is what open looks like. Again, good deformity correction, good symmetrization of the thorax and of the ribs and of the lung volumes. And this is what she looked like. And the thing you do get in the open, maybe the last young lady wasn't the best example of this, but this young lady, you do kind of see that on either side of the incision, you get some atrophy of the paraspinal muscles through the level of the fusion. I think that's probably because, and I think we see this in all kinds of spine patients who have midline open procedures, that even the healthiest patients will get some change in their muscle bulk and their muscle cosmesis. And, you know, the thought here is that the minimally invasive surgery may help us with that. And that was my early impression clinically, but we also looked at that. I'll talk about that in a little bit. In terms of complications between the groups, the minimally invasive, I did have one screw removal. And this is part of this was related to the technique where you drop wires as your initial finding of your pedicles. And I tapped and test the tap, but then when I put the screw in, there must have been a small breach because the tap tested fine and palpated fine. And so the patient had a little bit of thigh numbness and pain post-operatively, and I brought her back a couple of days later and took that screw out, and that was the L2 screw, and she was fixed down to 3. So I just left it out. She had screws on the other side and a screw at 1 and 3, and she went on to do very well. One of my happiest patients in general. And then the open happened to have a non-union in it, a revision at 3 years post-op for non-union, which is usually when those non-unions show up. They don't usually show up before 2 years. So in that comparison study, we thought we compared well with less blood loss, better scores, and faster recovery, even if they didn't reach statistical significance, and less length of stay. So we were happy with that comparison study, although it would be harder to generate a difference now using the ERAS protocols, because I think the differences are much smaller. Open patients leave on an average at 3 days, and the minimally invasive patients about half the time go home on day 2. So it'd be harder to develop a difference now. They all go home so fast with these ERAS protocols. So I was interested in learning curve data for this procedure as just an example of actually just in general how we all learn as surgeons and how we all progress through surgical techniques. And part of that was there was a big rash of papers that came out in the Scoliosis Research Society talking about learning curves being sort of having an initial shoulder, but then flattening out. And so we wanted to look at that with the minimally invasive technique because, again, the cadence of the operation was different than I think we were used to, and the operation just flows much, much differently. So it was really about learning how to do something new. And so we wanted to kind of look at that. So over 12 years, we looked at all the relevant variables. We looked at the first, about the first third of cases, the second third, and the final third. And with no change in the surgical technique, keeping everything uniform. We've already talked about this in terms of the incisions and the submuscular tunnels and looking at all of the clinical variables. All 3 groups ended up being very similar. Although patients started getting bigger. I don't think I was any more aggressive with the minimally invasive procedure, but patients started getting bigger. So you see their BMI creeping up. You see blood loss per level went down between the groups. OR time started going down per level through the groups. And length of stay also reduced through the groups per level. So, all these differences actually ended up reaching statistical significance. And this is just comparing the 3 groups. The only thing I would say about group 3 is you see a little bit more correction, but if you look closely at that X-ray, you'll see that it's also a larger diameter rod. So the one variable that did change, the minimally invasive sets we were using, we're able to take 5.5 and 6.0 rods. And so I think that's a little bit of the influence that you're seeing there in that group 3 photo, which looks a little better derotated, maybe a little more correction. So in terms of outcomes, there was really no difference. And this was a little disappointing because there is some good data in the deformity literature, both in adults and kids, that surgical experience reaches the level of outcome. So actually, it's different than some other procedures where expertise will lead to fewer adverse events or fewer complications, but not necessarily reach the level of outcome. In scoliosis surgeries, there is data to suggest that can happen, but we didn't see that. I mean, the outcomes, like I showed you initially, were as good as the best study group outcomes for those curve types. And it looked like every time there was a CT evaluation for any reason, or we looked at all of those, and we didn't have any patients with any clinical complications or non-unions on CT. So the first 20 cases seem to be, important in terms of learning curve, and that's a pretty standard number in terms of learning to do newer procedures or learning to do new techniques at 20 case. But we saw improvements really throughout the cohort. So I think that just shows either I'm a slow learner, or we can all keep getting better with time if we concentrate on proficiency throughout our careers. And this was the final study I was interested in. So not just looking at benefits such as outcome scores or blood loss, but trying to see if we met the standards for minimally invasive spine surgery in terms of tissue markers and in terms of muscle bulk changes pre and post-operatively. And so paraspinal musculature is one of the stabilizing forces of our spine. We're trying to minimize our damage to it. When you do an open approach and you peel the muscles all the way off the midline spine and then retract on them, there's been studies showing iatrogenic damage to those muscles. Some of it related to retractor time, but some of it just related to the approach. You obviously get scar tissue formation and denervation of those muscles and loss of muscle bulk. So we were hoping that if we paid attention to minimally invasive correction, that using these 3 smaller incisions, and really we almost never use a self-retaining retractor in these. That is another area of sort of worth noting, is that you have to have an assistant that's good with the MIS retractors that we just use Army, Navies, and some head and neck retractors for the submuscular tunnels, but there's very little, we never set anything in place and don't move it. It's just sort of gently moving everything around as you go, and the assistant needs to be in sync. So that is an important thing to note if you're going to try this out. So we looked at the standard tissue injury markers for spine surgery. And then we looked at paraspinal muscle atrophy, trying to get MRIs somewhere between 9 months and 18 months post-operatively. And so we enrolled 39 patients, and these were the inclusion criteria. And we tried to standardize for levels roughly, just so we were getting MRIs through the same, measuring through the same levels with the scans. And then we got a research protocol done with ARA in terms of exactly what we looked at in terms of cuts. And so these were the cohorts. And again, you see sort of the same pattern. MIS takes a little longer and has less blood loss. Length of stay was a little shorter. And here you see the open kind of shortening in terms of length of stay as the early ERAS stuff starts kicking in. Here you see the minimally invasive has less CK out to about 3 weeks. Aldolase actually lingers a little bit longer, but again, less than the minimally invasive. And this is just going through the standard PROs that we collect on everybody. And you see this, in this, you kind of see the same sort of getting better a little bit faster in the minimally invasive, but you do see topping out the MISs at 4.6 and the opens at 4.4. But again, that's a very standard average for idiopathic scoliosis. And then we looked at the differences in the paraspinal muscle area, and T6-7 was the level that consistently we had a good view of across the MRI. So that's the one we measured. And you see that we really had less change, less loss of muscle bulk with the minimally invasive. And this was just an example of the muscle measuring that we did using the T2 axial MRI. So trying to get a good look at what the residual muscle bulk was. In terms of radiographic parameters, the only thing that was different was residual proximal thoracic curves were a little different in the open. And the only thing I would attribute that to is a couple of the opens had what you might call a Lenke 1+ character. They had a little bit of structure in that proximal thoracic curve. It's very, very important for their long-term clinical result to get their shoulders perfectly even. So even though there was a little bit of proximal thoracic curve there, usually that's a residual curve above the rods, and you're correcting at that T4 or T3 level to get the shoulders perfect no matter what. So you really don't leave until that's done. But that's probably the reason for that small difference in proximal thoracic curve. But then you see at follow-up, it was the same. So, and everything else was basically comparable. So in terms of our final results, they had really less tissue trauma by serum levels of some indicators. The paraspinal muscle areas had less loss of muscle bulk, although they both had a little bit, probably having to do with having had a surgery. And outcomes were the same. MIS took a little longer, but less blood loss and shorter length of stay. So throughout all these examinations, I think the themes were less blood loss, less tissue trauma. We used to have shorter length of stay. I think that would be harder to show now using the current ERAS protocols for idiopathic scoliosis. And most of our studies were 2-year follow-ups, although we do have a cohort of patients that were able to get back and follow up longer than that. And I actually saw a 10-year young lady back about 2 months ago. So we're starting to collect that extra long-term follow-up patient group as well. And I think this is interesting for everybody. Before I started doing just deformity, I actually started using this same technique for supportive reconstruction after spine tumors. So taking out a tumor in the front and then flipping them over, and then doing an MIS posterior fusion in the back instead of an open. I think it may have some indications for some trauma and post-decompression instability. I think that this is tougher to use in terms of adult collapsing spine deformity. I have done a couple of cases that have done very, very well, but workflow gets much, much more complicated once you're trying to integrate perfect matchup of lumbar lordosis to pelvic incidence and hooking into pelvic fixation, which I think is a must in those collapsing spine reconstructions. But I think once you figure out this workflow, cases may take a touch longer, but you have a high potential for reducing blood loss and morbidity for thoracic and thoracolumbar instrumentation and fusion. So this is something I think probably is universalizable, but is going to take some work to get the approach tuned up. But that's it. Is there any questions or any thoughts?
Matt, thank you so much. I'm sure there are going to be some questions from people that know more about this than I do. I want to say that I think it's really great that you have so much patient-reported data outcome, data to report patient-reported outcome data. And I know you guys have been very tenacious about that and continue to do that with your group. And Eric Tremez is known for that nationally. He's on he's listening in on this too. I wonder if you would indulge me just for a minute. We have time because we go to 5 o'clock. There are some people on this Zoom who are experienced spine surgeons and some who know very little about it. I wonder if you would just give us a couple of minutes about your approach to a teenager that gets sent to you with quote unquote scoliosis. Because I think we have some people from the lab and some other that just, not everybody's going to need surgery. And just, if you don't mind, just give the introduction that you kind of skipped over, like you were talking to a lot of spine surgeons.
Yeah, sure. Let me pop back to this picture. So anytime a child comes to you with idiopathic scoliosis, you're going to divide up your treatment, or your treatment is prioritized based on whether they're skeletally immature or whether they're skeletally mature. If they're immature and they have growth left, we have conservative options to try. And so the first is if they're at risk for further progression and they have a smaller curve, there's level 1 data from the BRACED trial, which was an NIH-funded trial from, I think, around 2008, 2009, that showed efficaciousness almost at any curve size up to 40 degrees by putting kids in these hard plastic braces. They have to wear the braces a lot, but the goal is to keep these kids from having curves of a certain size. And there's a wide range of data at what point these curves become clinically important. And there's also an individualization component of that. What's important to your patient in particular, as opposed to patients in general. But so in skeletally immature patients, we have bracing, and now we have potentially tethering, which is a growth harnessing surgical corrective technique that's a little bit less invasive, but has uneven data. Even 20 years after it's been tried, I mean, people started doing growth modulation in the late 90s, early 2000s, and even the current best systems still have complication rates in the 20%, 25% range. So that's but for the growing patient, the perfect size curve, that is an option I think that many parents would like, some patients are interested in, and I think can really help some people have a great result. In terms of patients who come to these kinds of procedures, if you just look at these 3 x-rays, you'll sort of see 3 right thoracic curves, but each of them has its own set of characteristics in terms of the compensatory lumbar curve, how tilted the ribs are. And if we examine these patients on the EOS machine and looked at them 3-dimensionally, they would have a much different 3-dimensional structure in terms of the growth disturbance. The growth disturbance seems to be centered in the front, and anterior overgrowth occurs, and that initiates a buckling from a force mismatch with the posterior tissues, both the hard tissues and the soft tissues. And that's the growth disturbance that persists, but that growth disturbance can happen in a different 3-dimensional manner depending on the curve. And so sometimes you will see a young person with a 50-degree curve that has almost no spinal deformity. And sometimes you'll see a patient with a 40-degree curve with a lot of spinal deformity. So the first thing that we tune into pretty quickly is, do the patients have unsatisfactory spinal deformity that their parents don't like or they don't like? So that's one very strong consideration. Pain is a much smaller consideration. Most of these kids, teenagers get back pain at the same rate adults do, 2 to 4% a year. So if a kid comes in with pain, the first thing we do is treat them with physical therapy. We try to get them feeling good the same as an adult, but some of them will have persistent pain. If that pain is over the apex of their main curve, that also has potential to improve with surgery. And then the final issue is the natural history of these curves. So once they reach skeletal maturity, so they're out of the brace, they're no longer growing, and their curve is a particular size. The old Iowa data used to tell us that this pattern of right thoracic curve was at risk for progressing through life at 50 degrees. And the lumbar curves may be at a slightly smaller level. But it turns out probably there's just a linear set of data. The bigger the curve and the worse the 3-dimensional structure, the more likely it is to progress. And so that natural history then takes into account issues with lungs, issues with persistent pain and deformity later in life. And so if some patients come see you when they're 20, 22, they're already progressing after skeletal maturity, which is its own very important factor to kind of take into account. So, I think that's just a brief overview of the how and the why these curves occur. And in terms of the surgical treatment, we've gotten there's been a long history from Harrington rods back in the 60s. And actually Tim Lowry, who was a spine surgeon here in Austin, was Dr. Harrington's first fellow. And, from Harrington rods to all the different iterations to now, you see we use almost exclusively 4th generation instrumentation of rods and screws. But complication rates were very, very high in the late 90s, up to 35%. And now with modern techniques, and I'm actually in a national QI database that tracks this. Modern techniques, and experienced surgeons should have complications less than 2% at 2 years. And so these have become very, very reproducible, very reliable surgeries with very good results, and then also very, very good long-term results in terms of how people do clinically. These curves that you see here fixed, the long-term data says that they really return to the normal health-related quality of life curve in terms of pain, function, and all the scores that we measured, whether it's psychological health or physical health, or and as that fusion goes down into their low back, the results become less good. So as you start taking away people's low back motion, which is what creates function for us, they do start getting lower physical function scores. So the goal is to keep this fusion up in the thoracic spine where the primary curve is, and to do a very, very reproducible, reliable operation.
Yeah, thanks so much. I see. I think Omar took his mute off, and we're listening to my voices. Omar, did you have a question?
Yeah, hi, Matt. Thanks for a great overview and presentation. I just applaud you for the rigorous review of your own patient data and trying to ask the question, is MIS worthwhile? One, is it safe? And then how does it compare to others? And then 3, what difference am I making? So the questions that I wanted to, and one other thing that was kind of cool to see was that we also showed in our review of the harm study data that the proximal upper thoracic curve can get better without instrumenting it over time. Like initially you showed that it doesn't, that there may be a difference with your MIS versus open approach, but ultimately over time, you're going to get good outcomes even without implanting it. The questions, I have one question that's technical and the other is more indications. So I'll start with the technical question. When you do the MIS approach, are you opening, you're saying muscular tunneling, but are you opening the fascia, up and down the spine? That's one. And the reason I ask it is because how do you get bone graft, all the way up and around and decorticate appropriately between your incisions? And then that's the technical question. The indications question is, what are your exclusion criteria? And importantly, do you think that the rotation matters? I mean, it appears that you always put an incision where your apex is, so you can probably get some hold of it, but sometimes you need to march up to that apex to get a good derotation. So who do you think who you cannot do this MIS approach for? And then along with that indications again is, what do you still, I know you show that the muscular atrophy is less, with doing the MIS approach, but at least from what I've taught and what I've seen, what I've been taught and I've seen is that I still don't think that's, like the standard open midline approach appears to do well. It's a good operation and people have good cosmetic outcomes after it. What remains your main thing? I'm definitely want to do this for this patient because I'm making this specific difference.
Sure. So the first question was, those were 3. What was the first one again?
The technique. Are you opening the fascia up and down? Even though?
So yeah. So the fascia, the length of the fascial incision is the same as the length of the skin incision. So you undermine the skin incision, carry it off to either side like the plastic surgeons do. Then you make a fascial incision that same length. Your submuscular tunnel, though, runs up under that fascial incision. So the lateral edge of the lamina and the facet are exposed at every single level. And I really do like a mini osteotomy at each level. I burr it out to loosen it up the same way you loosen up opens. It's not an open ponte where you're excising, the ligamentum all the way across, because I'm not visualizing ligamentum. But there's been a movement to do these extra canal ponte osteotomies, whether it's with a bone scalpel or with a burr. And I do that here. I do burr out the facet and the entire superior tip of the facet, so it's looser. So, and in terms of getting the bone graft all the way up and down, yeah, you just put it there. I mean, you have the submuscular tunnel, and that is the moment where the assistant has to perfectly hold the retractor as you kind of place all the bone graft on every single level of bone. But I've never wanted to compromise on that, because I was concerned that those biomechanically weaker areas that don't have a screw on either side would be at risk. Now, it turns out that's not where non-unions occur. I mean, the only non-union I've had was at the bottom level, which was a shock to me, because I thought it would be somewhere in these bridges. But all the CT scans I've had, the bridges look just solid. So yeah, getting it bone grafted is I think a necessity. Second question was
indications. Like, what remain your what are the absolute exclusion criteria? Like, who cannot get this operation?
Well, I think I mean, I don't do it on curves over 70 degrees, because I mean, I've done one kid at 70 degrees and he did fantastic, and I was sort of like, that was probably about 2013 or 14, kind of in the first part of our experience. And it was so hard. It was so difficult because of the displacement off the midline, and I was trying to keep the incisions midline so they looked symmetric and nice. And it was a ton of work. So 70 degrees has been my top end. But other than that, I talked to everyone with a Lenke 1 curve about it. And I would say 92, 94% choose it. And I always put it in the context that, you know, the open procedure has 10,000 patients in the data, and I have 100. And if you add up the 2 other people in the country who like to do this, you know, maybe we have 500 in the database total, you know, so we have much, much less overall data. And I do have some people who choose the more common, you know, bigger data procedure. But I think 70 degrees, they start to top out. And then the other, you know, I don't do Lenke 2s because the compression distraction stuff for the minimally invasive still isn't very strong. And so, again, and getting that shoulder leveled in a Lenke 2 is very important. And
the last thing that I asked was about, you know, the absolute, you know, what do you think really makes it worthwhile to do the MIS after all the data you've shown?
I mean, so better is better. And I think the history of the last 20 years of scoliosis surgery is people have been, you know, whether it's changing to 4th generation instrumentation or adding Ponte osteotomies, or, you know, more aggressive osteotomy type resections. And, you know, I think the thing we kind of see over and over is we do a better operation, and then eventually it spills down into the outcome. So what I see is fewer people beaten up by surgery. I see people recovering faster. My clinical impression is the same as these scores, that people get better faster, they have less blood loss. But then they also have like less late pain, which if you look at late pain in these folks, you see that their pain levels are no different than the average population. But when it's site specific, so when they have some thoracic aching once in a while instead of low back pain, they attribute it to the operation, even if the data doesn't. And so I see less late pain. I mean, I see less of that late aching. They have almost, you know, the group of people who come in at 2 years and 5 years with 0 and 0 on their pain score and their Oswestry is fantastic. And I think that shows up a little bit. I have that impression. So I think better is better when you're talking about blood loss and tissue trauma.
That's excellent. No, thank you so much for that answer. I do love the late pain piece, because it is something that they continue to complain about, and they do attribute it to the surgery. And it's just, you know, how do you do anything about that? So that's great to hear.
And it always strikes me as odd that it doesn't play out in the data, but I mean, the data is clear how well they do, and it's probably just in some background of some back pain we get. but maybe that's from muscle atrophy. I mean, maybe it's from some muscle discoordination. Maybe it's from, some of the things we do. So.
Hey, Matt, I have a question about the last part of your talk. I understood that when you did your comparisons, you did a historical matched control because you had already switched over to doing it this way. And so that you didn't have comparable patients, that you weren't doing your own randomized study. But in the third group, what was your control? How did you have the open group, and how were those comparisons made for the biochemical markers?
Oh, sure. So it was people that chose the open.
Okay.
And, we do an enormous amount of open surgery. So Lenke 1 patterns that chose the open, but I also included some Lenke 1+s. And so what I mean by that is the left upper curve is not technically structural and bends, but there's a touch of shoulder asymmetry. And so in those patients, the algorithm is to stop at 3. And so we did go up 1 level. Now, we didn't measure through that level, but there was a group of patients where we went up 1 level. So.
Okay. I saw John Stokes put something in the chat. I don't know if that meant he was going to say something or. Maybe not. Any other questions for Matt about this?
Hey, Matt, Rory here. Great talk. I was curious, just you kind of touched on it a little bit, but just your sense of the long-term protective effect of this technique in terms of distal junctional pathology.
Right. So in terms of distal junctional pathology, you just don't see a lot if the level choice is proper. And I've only done a couple of people down to L3, a couple of like 1A, 1AR modifiers. So a couple sweeping curves down to 3. And one of them had a complication at that 2-3, which made me wonder if as the lumbar spine gets more, and that's where you see them in the open too, right? You see your non-unions at the bottom level some over half the time. And that's probably because it's the most mobile, least controlled level, right? Every other level's got multiple screws above and below it. And so that's the only patient I've seen. So you don't see a lot of distal junctional pathology in general unless you're going down to 3 or 4. And so I haven't noticed a difference because most Lenke 1s don't have a LIV of L3 or L4. It's usually T12, L1, or L2.
Fantastic. Thanks so much. I really am impressed with how closely you follow these people and haven't just accepted this is the best way to do it. We're going to just keep doing it. So I really I think it's great. I don't see any other hands up or questions coming out. So I think we'll finish a few minutes early. And thanks again, Matt, for a fantastic talk. And thanks for joining our department.
Great. Thank you, Nick. Thanks, everybody.
All right. Good night, everyone.